Hello and welcome to the NDARC weekly webinar. My name is Bianca Varney and I'm a researcher at the National Drug and Alcohol Research Centre, and I'm today's chair. Today we are hearing from Clare Rushton, who is a PhD candidate at the University of Wollongong and a clinical psychology registrar. Clare's research investigates the experiences of people who are affected by a loved one's alcohol or other drug use, and how to effectively address their needs through strength-based research and service provision. So today, Clare will be talking on understanding the support needs of families affected by a loved one's alcohol or other drug use. Our panelist today to help discuss her works is Robert Campbell, who is a program manager at the Family Drug and Gambling Help, which is a program of within the Self-Help Addiction Resource Centre, also known as SHARC. To make the most of our time with the panel, we'll be taking questions through the Q&A function. Please feel free to pop any questions into the Q&A box, and we'll do our best to get through as many as possible. Before we begin, I want to start by paying my respects to the traditional custodians of the lands on which we meet today, which in my case is the lands of the Bedegal people. We pay our respects to elders past, present, and extend that same respect to any First Nations people here today. So I'm delighted to introduce our speaker on this important topic, Clare Rushton. Clare, would you like to turn on your camera and mic?
Anyway, thank you so much for the introduction, Bianca, and hello, everybody. So as Bianca said, my name is Clare Rushton. I'm a PhD candidate at the University of Wollongong and a psychologist. I'm completing my clinical registrar at a not-for-profit in Newcastle. So I'm coming to this work as both a clinician and a researcher. So the work I'm going to be presenting on today is some studies that I've been working on over the last 4 or 5 years, and that's made up the body of my PhD, which I actually just submitted last week. So I'm feeling very good about that. So my research, as Bianca introduced, is looking at understanding the experiences and support needs of families affected by a loved one's alcohol or other drug use. So I would also like to start by acknowledging and paying my respects to the First Nation people on whose lands we're all joining from today. This photo is of Newcastle, which is where I am, and it's the lands of the Awabakal and the Worimi people, and it's the lands on which I conducted this research. And I'd also like to extend my respects to the other First Nations around Australia on whose unceded lands participants in the studies that I'll be talking about live. So I'd also like to acknowledge everyone that's contributed to this body of work. So that includes my research team. A big thank you to my amazing supervisors, Pete, Bryony and Ali. And importantly to all the participants whose lived and living experience is represented in the work that I'll be talking about today. So this research has been supported by the Australian Government Research Scholarship and the MOCRE. So to start with some context, globally, it's estimated that over 100 million people are affected by the drug or alcohol use of someone close to them. And this group of affected families that we're talking about are often described as a hidden population, as it's really hard to gauge the actual prevalence. And this is for a number of reasons. Firstly, because families are often not formally recorded or identified. Many of them don't seek help, and many of them don't kind of identify themselves, or they're not identified by services and needing support. So some recent studies have helped to give us a bit of a sense of the scale. For example, this recent study that looked at the prevalence of those affected in Germany found that nearly 1 in 10 people are affected by someone else's drug use. So the impact on families can be really profound. Families are at greater risk of mental health challenges, physical health issues, relationship breakdowns, and they often experience really significant amounts of stigma. And this includes being blamed for their loved one's substance use. And that can in itself compound the stress that they experience and make it a lot harder for them to seek help for themselves. So despite these challenges, support services for families are quite limited. But what we do see is that when families are supported, it not only improves their own well-being, but it also has been shown to improve outcomes and treatment adherence for the persons that's using drugs and alcohol. So it's a win-win. So throughout this presentation, I'll be using the term affected families to describe any family relatives or friends, or really anybody who identifies as being concerned about or impacted by a loved one's alcohol or other drug use. I'll also be using occasionally that acronym AOD, and that's referring to the words alcohol and other drugs. So historically, families affected by a loved one's substance use have been more often stigmatized, blamed, or pathologized rather than being supported. And when we look at the way that they've been involved historically in treatment or support services, the focus has largely been on how we can use families to encourage their loved one to get into treatment and to maintain abstinence. But while this is a really important area of work, I think we need to also acknowledge that some people who use drugs and alcohol may not ever feel ready to seek treatment or may not want to change their use in any way. So instead, this thesis that I've been working on takes a bit of a different approach, and it centres families as a population with support needs and strengths as popular in their own right, rather than as a tool to help somebody else's goals or recovery. So this research is guided by a model called the stress strain coping support model that you can see on the right of the screen there. And this really offers a non-pathologizing framework to understand families' experiences. It recognises that families, the experience, so we'll kind of start from the top down here. So they experience a huge amount of stress related to their person's drug use. And then this stress can become a high amount of strain. So the strain might look like psychological or relational strain. But this model also highlights, you can see the two circles on either side, that families develop coping strategies and that the amount of support that they receive. And these things can actually buffer and help them from reducing that amount of strain that they're experiencing. So through a series of 4 studies using different research methods, this thesis aimed to, firstly, identify families' characteristics and wellbeing and explore patterns in help seeking. Secondly, to evaluate the effectiveness of specialised family AOD interventions. Thirdly, to examine the feasibility of an intervention delivered via video conferencing or telehealth. And last of all, we wanted to identify family strengths and look at how best to support their building resilience. So here is the first study of this body of work, and this one's titled Characteristics of Family Members Affected by Another's Alcohol and Other Drug Use in Australia and Correlates of Help Seeking. So this study is under review, but it's not yet published. So just keep in mind the findings that I am presenting today might end up differing from the publication that comes out later. So study 1 really aimed to build a clearer picture of who is being affected by a loved one's drug or alcohol use in Australia. So firstly, this study aimed to look at describing demographic characteristics among affected families and looking at whether their experiences really differed depending on the relationship that they had with the person using substances. So this, for example, is whether someone is a parent or a partner. The second part of the study really focused in on that help seeking, what types of support families are using, what factors are associated with accessing certain support, and maybe how long it's taking them to seek that help. So the study presents the findings of the Family and Friends Survey, which was a national cross-sectional study of Australian family members. Participants were recruited via social media and from family support organisations, and we started recruitment in September 2023. So to be included in the study, participants had to be English-speaking Australian residents aged 18 years or older who were currently or previously affected by another's alcohol or other drug use. So participants would have seen an image like this come up on their social media where they could click through a link to a survey. They were taken to a landing page where they got information about the study, and then they could choose to complete the online survey, which took around 15 to 20 minutes just on their phone. So a little about the survey itself. It was developed in consultation with some lived experience experts that we were lucky enough to work with, and it included some questions about participant demographics, including that just getting a bit of an idea about their loved one that was using drugs or alcohol. We also asked some questions around their psychological well-being and a little bit about their help-seeking behaviour. So we ended up with 1,756 participants who were included in our analysis. 35% of those identified as being the partner of a loved one who used substances. 28% were parents, 13% were adult children, 10% were siblings, 8% were friends, and 6% were other family. And you can see those other relationship types listed along the bottom there. So the vast majority of our participants identified as being female, age around 54 years, and who were born in Australia. So we had participants represented from every state and territory across the country, with half the sample residing in regional or remote areas. 69% of our sample were employed, and over half had completed university education. So just under half of our participants reported living with their loved one. 14% reported no longer having any contact with their person, and 3.6% actually reported that their loved one had died. So now looking at their loved one's characteristics, so 71% of our participants reported their loved one's primary drug of concern to be alcohol, and that was followed by methamphetamine at 13%, cannabis at 8%, and other drugs, again listed across the bottom there, you can see the breakdown, but made up that final 8%. So the majority of participants reported that their loved one was a male, and over 1/3 of our participants reported that their loved one had actually accessed some kind of drug and alcohol treatment in the past, and 18% that they were aware that their person had injected drugs at some stage in their life. So participants reported being concerned about their loved one's substance use for an average of 9.5 years. So I think this really just speaks to the length of time that these family members are sitting with this as well. So now to look at their psychological wellbeing. So over half of our participants reported high caregiver burden, and more than 1 in 5 reported recent suicidal ideation, and that was in the last few weeks. And concerningly, this was particularly high among adult children, with almost 1/3 of the adult children that completed our survey reporting that recent suicidal ideation. So you can see on this right side here, this was the measure of psychological distress. And we saw that over half of our participants reported clinically significant psychological distress. So that was rated in that high or very high range. So you can see these coloured bars here, just below that statistic. And this really shows the proportion of each participant reporting that high or very high distress. And this is broken down into those separate relationship types. So you can see at the top there that 62% of adult children in our sample reported that high distress. I think when we look at that suicidal ideation as well, that makes a bit of sense consistently. And as we look down the list, we can see that over half of parents and partners are also reporting that really high psychological distress. And as we move down, we can kind of see that those more distant relationships, that distress level starts to drop off a little. And this really fits with the literature that we see that those really close relationships are linked to carrying more of that strain. And as that relationship becomes more distant, that strain drops off. So regarding participants' own substance use, we saw 15% reported risky drinking, 20% reported recent illicit drug use themselves. And this was broken down into these 3 main drug types. So the most common was cannabis, followed by non-medical pain reliever use and non-medical tranquilizer use. So now to the families help seeking. So this figure shows families who accessed any support for themselves. So this was in regard to their loved one's substance use. So any help seeking really meant formal support, like speaking to a psychologist, or it could have also included any informal support, such as even talking to a neighbour or a family or a friend. So we saw that the majority of participants really delayed seeking help for at least 1 year after becoming concerned about their loved one's substance use. And on average, participants were taking 6 years to seek any sort of support. So remember, this even includes speaking to somebody about their concerns. So when we look at this group here, so the 9% that didn't seek any sort of help, we can see from the top here, we can see that friends were, again, this is the proportion of people that didn't seek any help. We can see that friends were the most likely to not seek support. Which again, if we think back to that psychological distress scale of those same rankings of different relationships, it's kind of what we'd expect. They were experiencing less distress and they were less likely to seek support. And I think as we move down, we see a bit of a picture being painted here that partners were the next least likely to seek support, but we actually saw that they were experiencing really significant distress. So there seems to be a bit of a disparity there. So here is a breakdown of the specific support types that families reported accessing. So this question, when it came up on the survey, participants were asked to just select all the options that applied to them. And these coloured bars that you can see here are just showing the proportion of respondents who access that type of support. So the support types have been grouped into 3 categories, and I'll just talk these through now. So at the top here, the most common type of support that was accessed was generalised formal support. And this was mainly through families talking to psychologists or mentioning things to their general practitioner, with 29% going to those other counsellors as well. Then we saw 64% using informal supports. So this was mainly talking to family and friends about their concerns, and we saw 44% were accessing those online resources. And then this bottom group here is called specialised family AOD support. And this is including things like peer support groups such as Al-Anon and phone helplines, things like family drug support that we have in Australia, and education programs like Smart Family and Friends. So we saw that 34% of people were accessing this support. And this was a group that we wanted to get to know a little bit more, because we know that these interventions seem to be effective. We know there's not a lot of them around, but we really wanted to know who is accessing this specialised support. So there's a bit happening on this slide, but I'll talk you through the important parts. So we ran what's called an adjusted logistic regression, and this is really where we combine a number of variables to see what predicts a certain outcome. So in our case, we wanted to see what factors predicted accessing this specialised family AOD support. So you can see all the variables we controlled for across the bottom there. So each of these dots and whiskers along here represents what's called an odds ratio. So when the dots and whiskers are completely on this right-hand side, it means that the factor is related to accessing that support. And if it's on the left side, it means it's related to not accessing support. So I'll show you what we found here. So when we look at who was more likely to access that family AOD support, we saw some patterns emerging. So families who sought support were more likely to be older. They were also more likely to report that their loved one had previously accessed drug and alcohol treatment. And then on the other hand, we saw that help seekers were less likely to live in the same household as their loved one, and they were less likely to drink alcohol at risky levels. So to summarise study 1, I think we revealed some really concerning findings. Participants reported really elevated levels of psychological distress and suicidality, and that was actually higher than what we see in the general population. So really concerning findings there. Despite these findings, families were also delaying help seeking, and when they did, they were more commonly accessing informal or non-specialised sources of support. And while these types of support are still really important, generalised service providers might not have that specific training or even feel that confident in how to help families with their specific needs and challenges. So that was something that really got flagged for us. We also got a bit of insight into who was accessing those specialised support services, and that's something we wanted to find a little bit more about as well. So that brings us to study 2, the effectiveness of psychosocial interventions for families impacted by another person's substance use, a systematic review and meta-analysis. So this study was published in Drug and Alcohol Review. So the aims of this study were to synthesise the literature that was evaluating the effectiveness of these interventions for improving the wellbeing of affected family members. And this was including on measures of depression, anxiety, distress, quality of life, family functioning and coping. And we also wanted to look at both interventions delivered in a group setting and those delivered in a one-on-one or individually. So a systematic review is really a big search of all the literature to find all the studies that answer a certain research question. So in our case, we wanted to find out all the studies that looked at the effectiveness of these interventions for families. So the review was pre-registered on Prospero and followed the PRISMA guidelines. And this over here is what's called a PRISMA flow diagram, and it gives a good overview of this process of sorting studies for inclusion in the review. So it starts up here at the database search, and we filter and screen our way through all of those studies. to the bottom here where we reach our final 19 studies that we included in the review that answered our research question. So now to look at the characteristics of those 19 studies. So 11 of them were randomized control trials. The majority were conducted in the USA, and most participants identified as being female, which again is consistent with our survey. Looking at the types of interventions that were being evaluated, most of them were delivered in that one-on-one or individual format. We saw 3 studies looking at interventions that were self-directed online interventions. And of the intervention type that was most commonly evaluated, we saw craft come up the most, followed by 12-step programs and the 5-step method. So of the outcomes that were assessed by the researchers, most studies assessed families' depression, distress, and coping. Interestingly, only 2 studies measured quality of life, physical health, and family members' own substance use. So now to some of the meta-analysis results. So you can see on the left here that the interventions that were delivered to individuals showed a significant reduction in depression and distress and improvements in family functioning and coping. So for the group delivered interventions, which are on the right here, we found improvements in depression, distress, and coping. So there were also some common elements that we saw across all of the treatments. There was an emphasis on providing families with education and helping them with information to understand what was going on for them and for their loved one. Also a focus on supporting families and providing coping skills. And some of these skills looked like supporting behaviour changes and effective communication and boundary setting as well, and really highlighting the importance of self-care. Something we saw a lot in the group programs was this element of mutual support that seemed to be a really, really strong component. So several limitations were seen in the studies that we need to take into consideration when we're looking at these results. And so of the 19 studies, 9 were rated as having a high risk of bias. There was also fairly small sample sizes and quite a high dropout rate in each of the studies. So that means a fairly high number of participants didn't actually complete the intervention. So the study participants were mainly middle class, Caucasian and female. And most studies focused on alcohol use, and there weren't many looking at supporting families affected by other drug types. And there were also no studies evaluating telehealth interventions. But keep in mind that was done, the cutoff for this review was 2020, so just before COVID too. So we also saw lots of different outcome measures being used to assess families' experience and only relatively short follow-up assessments, which makes it hard to know whether the improvements were sustained longer term. And again, that limited assessment of physical health and substance use. So the review showed really promising outcomes for the effectiveness of these interventions for families, and it also highlighted some gaps in the literature. So firstly, around looking at interventions delivered online via telehealth, which is going to be really important when we think about increasing the accessibility of this support for families. And the second thing that we saw was that there was a real gap as far as other substances, so supporting families affected by methamphetamine use, which we know is particularly prevalent in Australia. So that brings us to study 3, which is called the feasibility of an intervention for family and friends affected by another's methamphetamine use. So this study was funded by NCRED and conducted in partnership with Smart Recovery Australia, and it's published in the Journal of Substance Use and Addiction Treatment. So the aims of this mixed methods study were to investigate the feasibility of a group program that was delivered to a cohort of families affected by methamphetamine use. So the study also wanted to look at the benefits and limitations of delivering the group remotely, and this was all done over Zoom. So I got to be as part of this study, to be part of the NCRED video abstract project, and this involved developing a 3 to 4 minute animation which summarised the entire research study in a couple of minutes. So big thank you to the team at NCRED and Insight for putting this video together, and I will play this for you now. Let's bring this up.
Methamphetamine use not only affects the individual using the drug, but it can also impact the well-being of their family, including their loved ones, relatives, and friends. Affected families face many challenges, including financial stress, involvement with the criminal justice system, and fear for the safety of their loved one and the entire family unit. This in turn can have consequences for their own mental and physical health, their relationships, and overall well-being. Unfortunately, despite the recognised impact that a loved one's substance use can have on the family, there is a scarcity of evidence-based treatments to support families as a population in their own right. SMART Family and Friends is a structured 8-module mutual support group developed in 2009 by Smart Recovery. The group has been adapted to align with the stress-strain coping support model and has been delivered both in person and online. However, prior to the current study, no formal evaluations of the program have been conducted. The aim of our pilot study was to assess the feasibility of delivering the program via video conferencing and to gather preliminary data on whether or not this might be helpful. To assess feasibility, we looked at attendance rates, participant satisfaction, and fidelity ratings, how well the program was delivered, and conducted semi-structured interviews with participants to understand what it was like for them to be part of the group. Preliminary outcomes were assessed using measures of distress, quality of life, and family functioning that were administered before people attended a group and again after the program had been delivered. We recruited 45 affected family members between March and October 2021, who were Australian residents aged 18 years or older. 88% of participants identified as female, 64% were aged over 50, and 69% were the parent of an adult child who used methamphetamine. The average duration of their loved one's drug use was 11.6 years. The interview data showed people found the mutual support component helped to reduce feelings of isolation and that they enjoyed the accessibility and convenience of the video conference delivery. Participants also spoke about challenges of the online format, noting that there was less chance to form impromptu connections with other group members. These results provide initial support for the SMART Family and Friends program and add to the literature demonstrating the feasibility and benefits of providing treatment to families independent of the person using drugs. These encouraging findings also show that a mutual support group delivered via video conferencing may be successful in improving mental health outcomes for affected families. These results are an important step towards getting families the help they need and merit further randomised controlled trials to assess the effectiveness of these treatments.
So I think overall, this study really showed that a specialised group intervention for families affected by methamphetamines was feasible. And while it wasn't a randomised control trial, I think it showed really promising outcomes as far as improving families' wellbeing. So the qualitative findings that were mentioned towards the end of that video as well, I think really highlight the value of listening to families' lived experience to really understand what they're actually looking for when it comes to seeking help and to help us to think about how we can best tailor support to meet their needs. So finally, to study 4, this one is called a qualitative exploration of affected family members' responses to methamphetamine use using the Family Resilience Framework. And this study was published in the Journal of Substance Use and Addiction Treatment earlier this year. So the aims of this qualitative study were to explore how families themselves make sense of and really respond to their loved ones' methamphetamine use. And we wanted to do this through a strengths-based lens. So the study used the baseline interview data from study 3, the one that we just talked about in that video there. And so just keep in mind when you're hearing these results that all the families in the study that I'm talking about now had actually reached out for help. They wanted to be involved in that intervention. So keep that context in mind that maybe these families might have been further along their journey than other people in a similar or different situation. So with the previous study, to be included in this study, participants had to be adults who identified as being affected by a loved one's methamphetamine use, We conducted semi-structured phone interviews in 2021, and the data from 24 participants was used in this qualitative analysis. And this was done using techniques called thematic analysis, aided by iterative categorization. So the final theme development of this study was informed by the Family Resilience Framework. This is that framework you can see on the right there, which really provides an overview of these key variables that are seen to facilitate healing and growth in families who are facing adversity. And this framework has been used for families who are dealing with chronic health conditions, who have experienced traumatic events. And we wanted to see how this might translate to a group of families affected by methamphetamine use. So this study focused on this top part of the model, which is called belief systems. So here are the 4 themes that we identified through our analysis that I'll be talking you through now. There are some quotes that I'll be showing on the screen, so if you just want to read those in your own time, and I'll explain a little bit more about each theme as we go through. So the first theme I want to speak to is called acceptance and resignation. So almost all participants spoke about navigating acceptance in the process of making sense of their experience, supporting a loved one who used methamphetamines. So in particular, families acknowledged this cyclic pattern of the addictive behaviour. And part of that was recognising their own limitations in how much they could or actually couldn't really influence their loved one's drug use. And I think at times this really presented as a sense of resignation and hopelessness, that they couldn't do as much as they would have wanted to. So family members who spoke about and acknowledged the effect of the stress and strain on their own well-being often also demonstrated this renewed empowerment to prioritise their own well-being. And I think this is really demonstrated in this quote here from a parent. So the second theme is called alternative perspectives to develop a compassionate view of addiction. So this idea of taking on different perspectives of substance use seemed to shape almost all participants' perceptions of their loved ones, also of themselves and their role in managing their loved ones' behaviour. So people spoke of hearing about different views of addiction through different support groups, through friends, through professionals, and that these different perspectives had supported them to come to a more compassionate understanding about drug use. And I think this is really seen in this comment here by a mother who described the process of learning about a trauma-informed perspective and the positive impact that this had actually on her own well-being as well. So the third theme is called transcendence and finding purpose. And this is really the idea of connecting with higher values as being important in families' journey towards making sense of their experience. So participants spoke about taking a step back from the role of supporting their loved one and coming back to reconnect with their own identity. And many people spoke about having lost this sense of connecting to themselves when they were diving into supporting their loved one. And this really even came across as re-engaging with really practical things like going and doing activities they used to enjoy. And this helped them to reclaim a sense of stability and a sense of who they were as a person and a sense of purpose in their own lives as well. So some people also spoke about faith and this trust in a higher power, which instilled a sense of confidence that they were actually part of something that was bigger than themselves. And I think as seen in this quote that's up on the screen here, people also talked about finding meaning and purpose through things like philanthropy, with this goal of giving back to others who might be in a similar situation. So the last theme I want to speak about was called holding on to hope and a positive outlook. And this presented in 2 main ways. So firstly, either relating to themselves or to their loved one. So people spoke often with encouragement about their own progress regarding their capacity to adapt and develop resilience, and looking kind of at the journey that they had been on themselves to develop what they saw as more healthy coping strategies over time. So hope and a positive outlook was also used as a tool in maintaining this trust in their loved one's recovery journey. And I think at times this was spoken about as a way to balance this huge weight of this uncertainty and grief that came with supporting their loved one. And I think this second perspective is really highlighted in this quote here by a mother. So this qualitative study really shows us that families are often drawing on deeply held values and emotional endurance. And I think by learning from what families are already doing, we can start to think about how we can design or implement some of these ideas into support service that can kind of lean on and support these existing strengths that families are already showing. I think these findings also really reinforce the need for services that are really flexible and affirming to where families are at in that moment, and that really see families as deserving of support in their own right. So as with all research, there are some few limitations that we need to keep in mind when we're thinking about these findings. So most of the people who took part were middle-class female participants. While we know that women are overrepresented as caregivers and that they're also more likely to seek help, we often don't hear from men, younger people, or from people from different cultural backgrounds, including Aboriginal and Torres Strait Islander people. So I think that's an area that we might need to look into more in the future. So the study samples were self-selected and recruited predominantly online. And in that, I think it's possible that families who might have been really struggling or might not have been ready to identify or recognise themselves in some of those ads would have been less likely to participate. The types of cross-sectional studies and cross-sectional research designs that we used mean that we can't determine causality as well. So I think particularly that survey study, so this was a non-representative sample, so the findings, because it was self-selected, so people who saw these ads decided to participate, it's really representing one group at one snapshot in time. So this isn't reporting on population level prevalence, and that's some work that we could definitely do in the future. So across all 4 studies, just to some general conclusions, I think we saw these really high rates consistently of psychological distress and mental health difficulties. Many people were delaying help seeking, and when they do, they're turning to these informal or non-specialised supports. And I think this is another really key thing that came out, that families are living with these stresses for a really long period of time, so many, many years. The research showed that these specialised family AOD interventions are not only feasible, but they're actually really effective and well received. But we do need to start thinking about how we can make them more accessible and more inclusive, and specifically tailored to the needs of different groups of families. So thinking about those younger populations, partners, adult children, and I think particularly those with no prior contact with drug and alcohol services as well. And I think something really important that final study really speaks to is that despite this long-term stress that families are carrying, they continue to demonstrate resilience. So we see them adapt, we see them cope, and we see them continue to show up and care, often with very limited support and recognition. So as far as future directions of this work, I think it's going to be important to think about how we might be able to train general health practitioners and professionals to work with families, as well as to strengthen support pathways between those general service providers and family-specific services as well, because we did see in that survey study that people were turning to those more generalised supports initially as well. So it's going to be important for government and policy strategies to formally acknowledge these mental health needs that we really see families carrying, and make sure that families are included when they're thinking about how clinical service delivery might be designed, and focusing in on families as a group with needs in their own right. So it's going to be also important to think about, because I mentioned with that survey study, it wasn't a prevalent study, and I think that is something that's going to be really important to start looking at how we can get that information. So whether that's including some questions in our national data collection methods, or in some of our drug and alcohol services as well. So here's some references from my talk. We also have some great services in Australia that I just want to put some references up to here, and we'll make sure that we can send around this information after the talk as well. So keep these in mind if you are a family member yourself and you're looking for support, or if you're working with family members. So thank you. Feel free to reach out to me via email, or you can scan this QR code if you're interested, and it will take you to a page with all the studies that I've talked about today.
Thanks, Claire. You can stop sharing your screen now. And I think we can all agree that was a fantastic presentation, and a big congratulations on submitting your PhD. That is no small feat. I'd like to now invite Robert Campbell, our panelist, to turn on camera on. And if you'd like to give a brief reflection on the presentation, that would be wonderful.
Thanks, Bianca, and thanks, Claire. Amazing body of work, and congratulations on your submission of your PhD. I know it's never an easy task, and the breadth and depth of what you've presented, there's obviously a lot to explore. And I'm struck just from the perspective of our own service and across the board, just that narrow demographic that does engage with supports and that overwhelming question of how to reach other communities, and in particular men as well. So really interesting reflection on something that's also strength-based as well. And that real sense of how stigma and shame seem to be such huge barriers, and what might happen if support could be engaged and connected with earlier as well. There's so much to explore, isn't there? And also knowing the positive impact that that has on the person for whom the family is concerned about the substance use, and possibly even where gambling might fit into that too. I love the model of the stress strain information coping model, because it is non-pathologizing, and I think families are so keen for support and information, but in a way that they're not feeling like they're being boxed in any way as well. And I think that opens up so many possibilities for help seeking. But there's so much to do around how to reach out to families and for them to know where the supports are. So fascinating findings, and it's great that those resources are there for us to look at and digest, because there's a lot of data there. So well done.
I really agree. That was amazing and a huge body of work. Now we do have some questions coming through. I'm going to start with one about feedback. Was there any feedback about what families found welcoming or helpful about the services they engaged with, given that many of the family members or friends in our peer education wellbeing group report that engagement with services has been stigmatizing, and so they've stepped away quickly?
I think a really important point, and not something that we directly explored in our studies, but I think it's a really key part. It kind of has me thinking about the survey study and that data that we had around where people were accessing that support. A third of those people that we surveyed had accessed that specialised support, but I think a majority had gone to speak to, for example, their general practitioners. And GPs are busy, they've got a lot of things they have to get their heads around, and they're faced with so many different presentations every day. And I think that initial contact is so key for such a stigmatized group, that if they are met with warmth and understanding and empathy in that moment and direction for where to go, that could be a real turning point, I think, in their journey. But I think, again, particularly also looking at the length of time that families are affected, and that delay, that huge delay we're seeing in even speaking to a neighbour or a friend about what they've been going through, just kind of putting our mind in what that might be like, of holding on to this for themselves for so long, and the courage it must take to go and step up. That I think that initial contact is so important. I'm not sure your experience, Rob, with your service, looking at what that initial contact looks like.
I would agree. And when you think about 34% of families coming through specialised AOD, feedback is often, if only I'd known about your service earlier, and getting the right support at the right time. So having things where people feel like they're able to reach out and be heard and be directed to where they might find helpful supports. But I think definitely being non-judgmental, which seems like a no-brainer, but having a service that's able to speak and meet with where families are at, because families come in all sorts of situations, but usually it's an acute crisis, and being able to both hold and recognise their concerns for their loved one, but also gently introduce and recognise and validate that they have their own needs. And that's a difficult thing for families to hear when they're really fixated on it. But if I could just get my loved one into detox, or this magic bullet, this magic service, and it's helping them to understand there's much more than just a simple solution, and how to have that in a warm, supportive way, that conversation.
Amazing. I'll put this next one for you again, Claire. What are the next steps for translating these findings into policy or frontline practice?
I think it's a really good question. I think in my mind, it comes to, I think, the point that Rob just made earlier around how we can support those treatment pathways and make support more widely available and also more widely advertised. Because I think one of these problems that we kind of hear about, I think, as Rob said, a lot of people say, if only I even knew you guys existed earlier. And I think that's a real difficulty that families face of not really seeing themselves represented anywhere. They don't really fit into that traditional caregiving space, or a lot of them don't identify as that from my research. And so I think helping families to feel seen and valid as a group, for them to then actually feel like they can even step into a space of saying, I actually do need some support right now. So from a policy perspective, that might just look like even basic advertising, making this group more widely available, making, I think, particularly those telehealth and maybe brief sort of interventions. So it's not a huge sort of step and a huge commitment for families, that setting up some kind of brief intervention or brief contact point where they get a bit of information, something that's a little more standardized potentially as that initial step, I think could be really important as well, just to help them to feel like we see you, you matter as a group, and we're here to support you, and these are your options. So keeping in mind, again, that it's not going to be a one size fits all, that these people are coming at different stages of their journey, different drug types, different age groups, relationships. And just, I think, as we would with any service, that we're not going to expect everyone to fit into this one box, but making sure from a policy perspective that we can fund different services so that families do have a choice.
Definitely agree. Do you have anything to add, Rob?
I'll just to say that as Claire was mentioning, I think that the challenge is there is no one size fits all, and recognizing that I think families hold, we talk about family as though it's one unit, but there are so many parts to a family which are uniquely different, and often it's the female caregivers in the context of either being a parent or someone who's holding a lot of the emotional load of that, and how families negotiate that and make sense of how they can reach out and get support. So it's a very complex thing in terms of what families are holding emotionally, and how to actually meaningfully reach out and recognise that they need their own support.
And jumping on the comment about high amounts of females, one of the questions was in regards to the high female attendance, I wonder, is that also associated with female facilitators? This person runs a group as a person identifying as a male, and we have an almost 50-50 split. So just curious was the question.
Really interesting. I'm not sure your experience with that, Rob, with the services you guys provide.
Yeah. It's interesting. We run a helpline, and we have a good, strong representation of males in that, and also an extraordinary diversity of people from very different backgrounds. Someone from Bhutan, someone from Vietnam. We have quite a diverse range, and someone from Iran. I was interested in that study that had studies from Iran specifically, which was really interesting. So that's interesting, but overwhelmingly, it's generally women who come to the groups. There are definitely partners in men, but generally that's been our experience as well. And it's trying to increase engagement for men that has been a challenge for us as well.
Amazing. Moving on to the next question. How much do you think getting estimates of relatives is limited by the fact that Australian privacy, information, and health laws? So they said, for example, a health service won't be able to contact the relatives of an AOD user in their cohort to offer them support as well without the family friend requesting that contact. So yeah, do you think these support services are limited by privacy laws, I think?
I've heard this come up a bit as a real barrier, I think, as far as drug and alcohol services expanding to supporting families. And I absolutely understand. I think it is really, really difficult, and maintaining that confidentiality is really important for the person that's seeking treatment. I think there are ways that maybe we could go about doing it. I don't think it has to be a hard and fast black and white thing. I think there are ways in kind of showing that families could be supported and included, whether it's looking at booking again, whether they're a family therapist or wanting to kind of bring the whole family in for a consult, or kind of setting up, I think it's all about setting up those expectations of the treatment that they're going into as well. And I think a lot of that also depends, as a clinician myself, I think is the clinician's level of comfort and how ready they feel and confident they feel in even having that conversation with the person who's using. So I think there's definitely space to have do a bit of research and work in looking at educating drug and alcohol clinicians in what their attitudes are around including families or providing support to families. How confident would they feel doing that? And I think that's definitely an area that could do a bit more work in.
I think so.
Yeah,
And also just helping families navigate the difference between, it's not as though they're wanting to overtake or be in control of a process, but rather to be included, the opportunity to be included, but also recognise that there can be fractured relationships where the timing of that isn't so appropriate. And that doesn't mean that you can't then provide supports for family and understanding and education. And again, that opportunity to recognise that they have their needs and how they could perhaps complement the treatment that's going on. So it's an important conversation, but definitely clear on your point. A lot of clinicians can feel uncomfortable because it can feel like it's a specialised area. But at the end of the day, it's around connecting and looking at that everyone has needs and everyone's under strain and how to support and navigate that as best they can.
Definitely, it's such an interesting perspective to also be thinking about how the clinician is feeling. I've got lots of questions here, so I'll move on to the next one. I was wondering, question is around if you could share about how you measured caregiver burden. Which tool or instrument did you use in your study?
Good question. So this was called the Zaret Caregiver Burden Scale. It's a 6-item measure, and it's used in, I don't think it's been used with families affected by substance use before, but it's mainly been used for families, caregivers of people with dementia, other health, mainly kind of chronic health conditions. But yeah, it's an interesting scale, and hopefully in the future we can do a bit of work in looking kind of across different caregivers and seeing how families affected by drugs and alcohol might kind of compare in the level of burden that they carry as well. It could be interesting.
Fantastic. There's another question here around whether there was did you have a chance to look at, or was there any difference in the study's finding based on the severity of the individual's substance use disorder?
It's a really good question and something that we haven't looked into. I think coming back to the focus of my research, I think the main, I've sort of been trying to stay with this idea with my thesis that it is purely about the family, independent of where that loved one is at. And I think recognizing, I think a lot of the way we've sort of understood families in the past has been contingent on their person and contingent on the person who's using drugs or alcohol. And so I think part of this work, the goal is to really uncouple that pairing and say that these affected families are a group that are experiencing these really significant mental health needs, and we need to support them irrespective of where their loved one is at, what drugs they're using, the extent of that use. So again, not a focus of my work, but I think there is some research out there that looks at that.
Definitely sounds like there could be many research studies on this topic, because it's all so incredibly important, so different. We've got another question here about whether you saw any differences between types of service access amongst those living in rural and regional areas as opposed to those living in major cities and city centres. Another
really good question. I don't think we did. I remember analysing this, and it's coming to me slowly. I don't think we saw any differences in the types of support as far as that list, but I haven't yet looked at, we also asked some questions around the modality of support, so whether it was online or face-to-face, group or individual. So that I think is an area that would be really interesting to look into as well, seeing if, I think my assumption would be that those in those remote areas would be more likely to opt for telehealth, just knowing small community confidentiality would become a real issue and wanting to maintain anonymous potentially. But yeah, definitely something that I'd be interested in looking into. I don't know if you've seen that at all, Rob. You guys offer?
I think what we've seen is surprisingly, whether it's metro or rural, people have been opting for online, which has been sort of one of the silver linings from COVID of everyone having to do everything online. And if someone's emotionally upset or they don't want to necessarily face driving home, whereas the convenience of just being able to log in, and we were surprised at the extent to which people would actually engage. So in rural areas, especially around stigma and small communities, definitely people would want to engage online, but not always necessarily. Actually, they valued the local support. So it just seemed to vary from community to community.
Look, we do have more questions, but I am aware of time, so I think we will finish up there. So I'm sorry if I didn't get to your question, but I just wanted to thank Claire, thank Rob. You guys have done, you've done an amazing job, and it was such an interesting body of work. Yeah, it was actually absolutely incredible. So thank you so much. We've got a list of upcoming webinars that should appear on the screen. So next week we have a webinar on hepatitis C elimination among people who inject drugs. Some successes, but still a long way to go. So please join that please join that next week. And thank you everyone for coming.
Thanks, Bianca. Thanks, Claire. Thanks, everyone.
Thank you.
Thanks, everyone.